Hello, welcome everybody. Thank you so much for joining. We'll just give people a moment or two to get connected. Thanks. Okay, I can see people are starting to enter, but maybe we'll just get started with some welcomes and introductions. And thank you very much to everyone for joining in the middle of what is a week that none of us really expected, I think. My name is Meg Davis. I'm the professor of digital health and human rights at the Center for Interdisciplinary Methodologies at University of Warwick. And I'm joined also today by my colleague, Tara Imalingat, who's Advocacy and Impact Coordinator for the Digital Health and Rights Project. We both work with that project here. Maybe we can just have the opening slides and then we can get started. Thanks, Javier. Great. So this is Strengthening Gender Equity and Rights in National Digital Health Strategies in East Mediterranean and MENA region. Thank you very much for joining us. And we want to let you know that there is transcription and there are captions available. So on this, previous slide, you can see how to access the captions. Thank you. So you just need to go up to the three dots over the More button on the top ribbon, if you can see that, and then you just follow those instructions to activate language, and you can select the language that you prefer to hear us speak in. It's not great, but it's better than nothing, so I hope that those of you who need translation can benefit from that. So I want to introduce our speakers today. We have a really wonderful group, really impressive set of experts in human rights and health and gender and technology. So first of all, our co-sponsor, Dr. Patricia Michiel, who is co-founder and chief executive officer of Health Enabled. And she also leads the Global Digital Health Monitor, which many countries have used to develop digital health strategies and assess progress. And she's also a senior associate professor at Johns Hopkins Bloomberg School of Health. Professor Arash Rashidian, who's coordinator of science, innovation, and data for impact for the World Health Organization's Eastern Mediterranean region, or EMRO office. He's also executive editor of the Eastern Mediterranean Health Journal, and affiliate professor at the University of Washington, and professor of Tehran University of Medical Sciences. Dr. Khaled Hassin, a longtime collaborator with the Digital Health and Rights Project. He's also a lawyer and industrial economist and leads the health cluster at the UN Office of the High Commissioner for Human Rights, based in Geneva. Catherine Johnson, who's a policy specialist with the HIV and Health Group at the UN Development Program. Ayman Sabea, who is co-founder and CEO of Egyptian social enterprise Shamsea, and also a medical doctor in his own right and a right to health researcher. And Tariq El Alawi, who is president and co-founder of Canaan Plus Morocco and the MENA regional focal point for the global network of people living with HIV. So thank you so much to everyone. Did I get everybody? I mentioned Tara. Okay, good. Thank you so much, everyone. Wonderful to have you with us for this really rich discussion today. So I just wanted to introduce briefly the Digital Health and Rights Project, which is the project that Tara and I work with. We are an international consortium that brings together academics, human rights groups, people living with HIV, health advocates, and others to collaborate in a transnational participatory action research approach to studying digital rights in health and advocating for policy change, with youth leadership very much at the center of our work. We've been working together for a number of years, most recently and currently hosted by SIM at University of Warwick. And we are co-sponsoring today with Health Enabled, which works at the intersection of public health and technology to co-create equitable solutions that drive a whole health approach. So really very pleased to have Patty with us today for that conversation. We did want to share with you a few of our resources and tools. So on the next slide, you can see some of our published work, publications, which are on the digitalhealthandrights.com website, including Paying the Cost of Connection, which is a recent study engaging over 300 young adults in 4 low and middle income countries to study digital health and human rights and advocate together. And on the next slide, we also wanted to flag our newly launched massive online open course on rights and health in the digital age, which has been developed by Universidad de los Andes as part of our collaboration. It's free of charge in Coursera, and it is English and Spanish. It's fully available in both languages. So if you're interested to learn more about your human rights in the digital age, it's a great place to start. So I would encourage everyone to check that out and to share it along. Next slide, please. So this conversation comes out of our work in collaboration with WHO to review national digital health strategies and to understand how they addressed gender equity and rights. And what we found in our review of 20 digital health strategies was that actually many did not address gender at all, and that quite a few did not really engage with human rights or equity concerns. And of course, this is a commitment of the WHO Global Strategy on Digital Health, which advocates for gender equity and rights to be included as part of digital health strategies. And so we decided to convene this series of conversations working with WHO, UNDP, and other partners just to reflect on what the challenges are in rolling out digital health, what some of the human rights implications are in the digital age, and to develop recommendations for WHO for the next global strategy on digital health. Now, of course, we developed all this weeks before the US and Israel attacked Iran. And so that has created a very odd and challenging moment for this conversation, which I think we should acknowledge, as well as underscoring the importance of upholding international human rights standards and humanitarian law and of protecting civilians at the current moment in the face of mounting evidence of attacks against schools, hospitals, and clinics. And so this may seem like an odd moment to talk about digital health strategies, certainly surreal. But at a moment of humanitarian crisis, we know that the first place many people will look for health information and services and support, if they have a phone, they'll be looking on their phones. And so the question is, what do they find there? And how could digital health strategies support the right to health at the current very challenging moment? And what is the role of digital health strategies in supporting that? So that's the conversation we hope to have today. So we can move on to the next slide. We've shared a number of recommendations based on our previous research, which I won't go into now, but we can hopefully return to these in the context of our discussion. Certainly there's a need for more research and more conversation, increasing digital health literacy, and facilitating spaces for people to share good practices. So that's very much the spirit in which we approach this series today. In the region, we know there are a number of digital health strategies under development. I think the next slide shows us, oh, sorry, I did want to flag, yes, thank you. I did want to flag the Global Fund on the next slide, thanks. The Global Fund is now funding work on digital rights as part of its new grant cycle. So there is an opportunity there, especially for civil society, to access funding to work with governments on strengthening data governance, on strengthening laws and policies to advance digital rights and uphold the right to health through social media, websites, and apps. So yeah, please check out these resources for more information about that. Next slide, please. So these are 3 member states that we know are planning to or are currently developing digital health strategies in the region in 2026 to 27, Egypt, Iraq, and Kuwait. And there are others that are reviewing and revising the strategies they have. So I think it'd be interesting for us to reflect on what the potential is at the current moment. So with that, it's a great pleasure I forgot to share with you the advocacy tools and reports that we have online, a checklist for addressing gender equity, rights, and inclusion, as well as some of these other checklists and resources for planning and developing gender and human rights responsive digital health solutions. Next slide. Great. Okay, thank you. So it's a great pleasure now to reintroduce Professor Arash Rashidian from World Health Organization in the Eastern Mediterranean region. Professor Rashidian, over to you.
Hello, good afternoon, good morning to colleagues. Many thanks, Professor Davis. And I'm extremely grateful for the initiative, to the University of Warwick, and also has enabled for hosting this important discussion and flagging it the way that it has been flagged. I mean, this is absolutely required. So I won't be talking for long, and there are many of the issues that I'm going to tap into. Also, Professor Meg referred to at the start of the discussion. The reality is that gender rights and equity concerns matter in digital health. And if in the next slide, I've listed some of the reasons that all of us are aware of. First of all, and this is unfortunate, but that's the reality, digital health and digital technology remains a male-dominated arena. So I mean, that's globally visible, but also in the many roles that are people who are designing such program or in charge of those in many countries are still majority male. So in a way, it's quite natural the gender roles might be missed because of lack of good understanding. At the same time, it's also if there are, for example, in a country, gender rights or gender-related issues are structurally not well addressed, then obviously those together, I mean, amplify the challenge that we are observing. Again, digital health, I mean, a lot of good things happening in digital era are done by the youth. But then when we talk of digital health is for the whole of society. So age-related challenges, again, in terms of rights and access and equity, are visible and important. In many of the strategies we talk about, including global and also regional strategies for digital health in EMRO, that I will refer to in a second as well, the issue of that, I mean, one of the main aims is to make sure that access to resources and access to health and health promotion and services are better done in remote and underdeveloped areas. But then underdeveloped areas have the challenge of that the digital technology may not be working really well. Many of the resources may not be there. The issue of cost when it comes to the literacy, the issue of the DPIs, digital public infrastructure, that remain limited in many aspects related to digital health. That's an effort that WHO is investing a lot on it in collaboration with the ITU. And then put all of this together, we have a technology force and a market force which goes really quickly and is well ahead of policymakers, is well ahead of UN organization, is actually pushes to move forward. And that means any approach that you want to take, you are behind of a new technology that is coming forward. Putting all of these together tells us we really need to have a deliberate, objective, focused attention to issues related to equity in digital health strategy, to issues related to gender equity, the issues related to the rights for the mobile population, for the remote areas. All of those are extremely important. Next, please. So within the I'm referring to some key documents here for reference. I mean, we've had 2 resolutions in the region after the global resolution related to issue. In 22 was the regional strategy and the related action plan for that. In 24 on interoperability of health information system, which is a key factor in data-related issues. Within those, next slide, please, access has been highlighted as the key factor, I mean, equitable access. So coming to the national strategies, I mean, we heard from Professor Davis a few words about the sort of some national strategies. I mean, we've highlighted a few more here. So for example, in Jordan strategy, there is a focus on people with disabilities. So that's an important factor. In Iraq, I mean, the Rafah strategy, there is a more comprehensive approach highlighting issues of urban rural areas, the poverty gaps, the gender-related issues, and including disabilities. In Pakistan and Egypt, we see also some of these aspects, important aspects have been addressed. But the reality is none of the strategies that we have are addressing it in a more systematic, covering all areas. And this is a lesson learned that we definitely need to inform the new global strategy, which is under discussion and consultation with member states. I mean, Meg referred to the fact that, I mean, the current situation is really hard. But this morning, we also had another consultation with countries of the region on digital health because of, I mean, the importance of the issue, even at the time of conflict and disastrous situations. Next slide, please. So to conclude, digital health has a potential, a strong potential to address the gaps, to address inequities. This is, I mean, what has been promoted for. This is how WHO is behind it and why we aim for further work on that. However, it has the potential also to augment existing inequities. It has a potential to actually multiply the sort of structural challenges we have in gender gaps, etc. It needs deliberate attention. It needs focused attention and effective intervention to address that. With that, I stop, and I'm really looking forward to listening to the experts, the so brilliant group of colleagues that have been put forward together in today's call, and listening to their advice and recommendations to go forward. Thank you.
Thank you so much for those insights, and especially for sharing sort of regional perspective and some of the efforts that have emerged in different countries, as well as you know, the remaining challenges with really attending to some of those gaps. So really helpful and appreciated, and hope you can stay with us a bit for the discussion, and please do chime in with the panel, if so inspired. So thank you, and with that, we'll move on to the panel discussion. So I've already introduced the speakers, so maybe we can just dive right into our conversation. So that would be great. Thank you very much. And I think we wanted to begin by reflecting on what some of the challenges are, in particular to addressing gender equity and rights in the region. And Patty, is our co-sponsor, I would love to start with you to kind of share some reflections. Thanks so much.
Great. Thank you, Meg, and thank you, everyone, and wonderful to be in such good company. I think one of the things, and I really appreciated the work that you guys have done on this, is that, like, unless you're looking for it, you don't know whether it exists or doesn't exist. And I think one of the main opportunities we had to start to systematically document whether or not human rights or gender was being included in national digital health strategies and policies was when we were developing version 2 of the Global Digital Health Monitor. And we were strongly encouraged to align with the WHO strategy on digital health, which highlighted this, need that you raised earlier to look at human rights, gender, et cetera. And then we started to work with countries to measure that. It was actually in Iraq, and I was glad Arash raised the Iraq digital health strategy. I had the privilege of working on that strategy in 2023, and we used the Global Digital Health Monitor version 2 to assess the enabling environment for digital health in Iraq. And they were very keen to include equity and human rights and gender considerations into their digital health strategy. But we know that it's very difficult to operationalize strategies, right? So you can have a very nice strategy that communicates, these ideals, et cetera. But then to translate those into actual action, and particularly in areas like gender, where so much of it is like systemic and cultural, and it's very complicated. So you have both gender as identity, but then you also have gender dynamics, where in most countries, as Arash pointed out, a lot of the digital health programs and interventions are being led predominantly by men. And yet the majority of frontline health workers in most settings are women who are having to use these tools and these solutions, et cetera. And unless they're designed intentionally for use by women, they will often cause harm. And we're learning this in terms of the research that we're seeing, that platforms and systems that are not designed with a gender intentional approach, or with the intention of addressing some of the challenges that you've flagged, will often have the unintended consequence of causing harm to people, simply because we didn't anticipate and we didn't design with this sort of safety first lens that a lot of femtech tends to take. and is good for everyone. I mean, a lot of times people are like, the gender intentional approach is actually not magical. It's basically human-centered design if you take into account all of the humans that are going to be, impacted or affected by technology. And so I'll pause there, but just to say that we do need to be a lot more like systematic and thoughtful in understanding the issues, but then also deliberate in how we choose to address them. Because if we don't choose to address them, they will cause increased inequity and, unfortunately, harm.
Thanks so much for that insight, Patty, and for the strong call for gender intentional design. I would love to kind of build on that and maybe turn to Tariq now for a community perspective from the region. What do you see as some of the challenges in the digital transformation of health? Thanks.
Thank you, Meg. Thank you for including the community perspective in this discussion, and also the perspective of the people living with HIV and other key population in the MENA region. I think one of the most important challenges that the community and the people in HIV especially face is the confidentiality and the accidental consequences of digitalization of especially for people living HIV and other marginalized communities. So one of my added value to this discussion is to bring the realities that are on the floor. And for example, in some contexts, the digitalization of the medical records links HIV status across different health services. And that's when people need medical care outside the HIV clinics. This information might become visible to other providers within the system. So this can sometimes lead indirect forms of discrimination. Patients might not be openly refused care, but they might receive very distant appointment, like unnecessary delays or administrative barriers. So for people living with HIV, and I'm speaking also about personal experience living with HIV since 2002. I started my journey in job in 2006, and I was registered to the health insurance system. But during like 10 years, I never applied for a refund for the simple reason I had no trust. I was not sure if my informations will be linked to my company. I was working in hospitality, so it took me a lot of time to really build this trust and be sure and be guaranteed that my informations will not impact my life, will not impact my personal life. So this is one of the challenges. And the other one is also concern the key population, especially the LGBTQ plus community. So in this environment, digital health platform can create additional fears among communities if they believe that their data could be accessed, measured, or linked to their identity. So I think that when legal and social environments are hostile, community might avoid digital health platforms altogether. So even if these platforms are designed to improve access to care, because here comes the security before any access to treatments. So this shows how digital health systems must be designed with strong safeguards for confidentiality and data protection and protection from discrimination, particularly for people in HIV and other key population. Um, and we can say that this vision or the digital health system can only succeed if communities trust them, and trust depends on strong protections for privacy, safety, and human rights.
Beautifully said. Thank you so much, Tariq, for making that point. And I think really underscoring the intersectional nature of confidentiality and privacy, that human rights can affect different people differently. And so these confidentiality issues are not the same for everyone, and that there need to be special, consideration for different groups. I know when you talk about the right to privacy, I could see Khalid's ears perk up because that is the language of the UN Human Rights Office. So Khalid, please share with us a bit about the work your office is doing in this space and what you see as the challenges and opportunities. Thank you.
Thanks so much, and thank you for having me also, and for this important event. As Tarek said, human rights anchoring from a right to health perspective, OHHR approaches a digital health through the lens of conditions of digitality, recognizing that health systems increasingly operate across interconnected digital and analog environments, shaping access, participation, and accountability. So these three keywords carry profound human rights implications. Hence, we use this as an analytical framework or approach to do right to health framework assessments and assess the systemic impacts on equality and dignity and self-determination, including informational self-determination, and to ensure digital transformation advances the realization of the right to health for all. We have done a comprehensive human rights assessment on mapping exercise last year on human rights and emerging digital technologies, and three challenges stand out: inequality, invisibility, including data gaps that are coming from pre-digital area on certain groups and persons, so persistent digital divides across gender, disability, age, income, and geography. Under digitality, we have also inequalities that reproduced through data systems and algorithms, often invisibly. They include the systemic exclusion of older persons or certain persons that are in situations of marginalization. And these are linked to caregiving technologies without safeguards. A second key point, self-determination and trust. We see weak safeguards for informational self-determination. They undermine autonomy, consent, trust, in particular for those in situations at heightened risk of human rights violations. As you know, no group, no person is per se vulnerable, but situations may affect them disproportionately. So be it women, children, migrants, or older persons. So there we have emerging technologies that have disproportionate impact, but also emerging technologies like neurotechnology threaten privacy, mental integrity, and agency if not well regulated. The third point, governance and accountability gaps, is something that is quite concerning. Many of the frameworks that we have analyzed still regulate tools rather than ecosystems. So with limited participation, transparency, and oversight, independent oversight. Also the data gap, weak disaggregated data systems constrain human rights monitoring across what we call AAAQ, availability, accessibility, acceptability, and quality dimensions, and limit evidence-based policy making. So simply put, innovation must not come at the cost of dignity or human rights protection. And a final word, the minimum core obligations, they apply also in times of conflict and armed conflict. So even the minimum essential levels, be it access to healthcare or other economic, social, and cultural rights, remain binding. And just to reiterate that human rights apply all the time, all through in conflict times, and need to be protected and respected. I stop here, Meg.
Thank you, Khalid. That was a lot of very rich food for thought. And I think you really hit on a number of very crucial points there that I hope now if Ayman is able to connect with us, you can also speak to how these are playing out in your work at local levels. Thanks. Go ahead, Eamon.
Thank you very much. That's very insightful. And I mean, when you've been talking about the plans of different countries in the region for the development of national health strategies, and particularly Egypt, and in preparation for this webinar, I had to do some research. And because I remember that back in November, there was an announcement by the Egyptian Minister of Health about the Egyptian National Digital Health Strategy. And till this very moment, this hasn't been published. I mean, it has been announced in November, but we're in March and nobody knows what the strategy is or where it has been or what it says. And I think this is really the core that I want to tap into, because it's, you know, and we've seen this in so many files related to healthcare. Sometimes we see officials with the relationships and links that they have with the WHO and different UN agencies, they feel compelled to check some boxes, you know, and we make it easier for them sometimes when we provide them the boxes to check. But in the end, if this is not a process that is truly owned and understood in terms of participation and involvement of the key stakeholders, it becomes a piece of paper, or it doesn't even become a piece of paper in this particular case. So when we're talking about having a national digital health strategy in Egypt and what it entails, we have to also bear in mind that this is what I described as a responsive policy. It's not something that the government is doing out of choice, but it's absolutely out of necessity. We have an ecosystem that is developing at the speed of light. We have digital tools that are being rolled out. People are using them with or without any sort of regulation. And of course, the peak of it was during COVID, when, you know, digital health has completely boomed. And we have an ecosystem that reacted to the gaps that were in the market by providing digital solutions. So now, for example, when it comes to mental health services in Egypt, this is primarily provided through digital tools. This is the main source of provision of this particular service. And yet, there are absolutely no regulations when it comes to this. When we're talking about something like teleconsultations and remote services provided through the public sector, one of the key companies that was providing telemedicine solutions for the government had to go through 9 years of approval taking just to be able to roll out these services in public settings. And it was only taken into consideration and was only implemented when a higher presidential political will has developed in this regard and was seen as something that would improve the service provision cycle. So in the end, we have a system that is highly responsive, and it's responsive to an extent that is sometimes a bit scary. So you know, we talk in Egypt about the fact that the best way to implement a new policy or strategy, or to even propose a new law right now in Egypt, is to produce a TV series about it. You know, we have seen so many laws and regulations and policies being implemented just as a response from a sitcom, you know, and this includes some things like legal family affairs, divorce laws, gender-based violence, custody laws, recently cyberbullying. You know, we have just had a series about abuse of technology in the context of gaming among children. The next day, the government and the parliament are convening, and they are, you know, they have a new law that bans Roblox in all of Egyptian houses, you know, and it's blocked just as a response from something like this. We've seen this about organ transplantation laws. So it's really, right now, if we can manage to put an important topic such as this into the public sphere, chances are there is going to be a significant response where people can respond to it. The only problem, as very rightfully so mentioned by Tariq, which is really appreciated, is that when this is happening, we need to consider that we need to acknowledge that people are going to be affected by it, and some people more than others. When it comes to the right to health in Egypt, it is seen by the political authorities right now as something that is for the masses. That we need to provide healthcare services to everyone, and sometimes everyone excludes individual people, because when you provide a service for everyone, you end up excluding people who require special considerations when it comes to these services, especially women in this particular case. Yeah, I'll stop here because I can just go on and go on forever.
We will definitely come back to you, Eamon. That was fantastic. Thank you so much for those insights. I'm not going to put our WHO colleagues on the spot, but I know that there are several of them on this call. So if they have access to Egypt's digital health strategy, this might be a really great time to pop the link in the chat so that we can all see it. So yeah, that would be, I think, very much appreciated. And I especially want to appreciate Ayman's comment about the right to participation, which is also grounded in other human rights norms. And I know UN Human Rights Office does quite a bit of work on this as well. When we looked at national digital health strategies, of the 20 we looked at, only two, UK and Ghana, had civil society participation listed in the list of people who were consulted. And so I just really want to underscore the importance of that for the next global digital health strategy, that we must have meaningful participation to surface these issues, but also to create better digital health literacy, to create better public ownership, and to leverage the digital health strategies to create more robust digital governance. So I'll get off my soapbox, but I just wanted to flag those issues, and would now like to pass to Catherine to share some of their work at UNDP on some of these issues. Go ahead, Catherine.
Thank you. I mean, I've really appreciated hearing from the other colleagues, and just to echo what many of them have said, the challenges we're seeing around digital health are equally systemic rather than purely technological. They're relating to how the strategies are written, but also to how the digital systems are being implemented, governed, and adapted in this rapidly changing technological environments. While we're seeing strong progress in the development of these strategies, however, as Patty, rightfully noted, the challenging is really increasingly lies in the operalization of those strategies. Had to get that out, sorry. In ways that really consistently embed gender equity and human rights as these technologies evolve so quickly. The persistent digital divides across, all the regions that we work in, we really see that different communities are still having lower access to internet connectivity, smartphones, and digital literacy. And if these health systems are designed around the assumptions of universal connectivity, they can unintentionally exclude the populations that the health systems are trying to reach. And, another challenge that we see is the need to anticipate how the digital systems may affect different populations as these technologies evolve. Many of the strategies we see address important issues such as privacy or data protection, but fewer explicitly examine, as we're talking about, the gender inequalities and systemic barriers faced by groups, or how data and digital systems may shape access to services over time. And as these technologies evolve, Tariq raised very important points about concerns and impacts of data privacy and how the systems may have different issues. And without this forward-looking analysis, there is a risk that the digital systems will unintentionally reproduce or amplify existing inequalities. And then another challenge is about the institutional coordination and governance. Digital health sits at such an intersection of all these different sectors, including health, telecommunications, data governance, social protection, and gender institutions. And it really requires a whole of government approach rather than strategies being led solely by a single technical ministry. And we often, Meg, as you just noted, we're not seeing a lot of different groups and other agencies, for whether it's civil society or other partners, being brought into some of these discussions. And then, as others have also said, that in parts of the region, the countries being affected by fragility, displacement, or climate-related pressures, these strategies are being implemented in really complex operational environments where institutional capacity and infrastructure are really uneven. So I'll stop there. Thank you.
Thanks so much, Catherine. Really appreciate those insights. And I see that Arash has turned on his camera. Did you want to jump in, Arash? Or
Well, I mean, that wasn't the main intention, but probably was many times. So I'm really enjoying listening to intervention from so many different angles, and the messages are coming very strongly. Everybody providing not only concept, but also examples of how it goes. What I want to highlight is that the challenges we have, and I think it was Ayman who referred to some of those challenges, is that how to get the solutions into the system, and which solutions are affordable and usable. So let's say, I mean, think of the data privacy related issue, the example that Tariq referred to in the case of HIV AIDS issue. So that's not just because of digital health. I mean, even without digital health, that's a challenge. Many of the digital health programs, even in high-income countries, that they safeguard the safety better than low and middle-income country is not because of the digital solutions are better. It's because the legal system and the judiciary system behind that is very strong. So even if you have access, or even if you have the potential to access, you will not do it because there is a system that would safeguard that. In low middle-income countries, those structural challenges means that if there is a sort of a bug in the system or a system that would allow and trust the individuals, there is no safeguard to ensure if someone goes beyond the trust level, they will sort of, that prevention is not working well. So we really need more interventions. I mean, what I'm really sort of asking and encouraging all of us, and also the academic community, we need more research studies that show which interventions are scalable and implementable, not in a very costly manner, but it's a way that can be done. Going sort of beyond the discussion of digital health, and with that I would end my intervention, is that we know that on equity-related concerns, it's not enough to have a good idea that I want to do this for equity. There are many research studies showing that people intended to do something good for inequity, and then the result actually increase inequity or in another areas. So in a way, evidence of effect of different interventions is really important. As Patty was saying, I mean, it's much easier to get the strategy right. It's much more difficult to make sure it's effective in practice. And that requires much more evidence of effective examples.
Thank you. Very well noted. I think it is very important to come up with those concrete examples of successful efforts to address inequity. I would say that something that for the Digital Health and Rights Project, something we've really struggled with and tried to consider is how we can learn from other approaches, especially in public health, for the digital transformation. And in particular, we really tried to learn from the HIV response and noticing how effectively communities living with HIV and their allies have mobilized both locally and transnationally on advocacy, providing peer support, developing low-cost innovations that aren't always brought to scale, but that continue to persist and will persist in the current conflict. We know that communities will be on the front lines and they'll be the first responders in many cases. So what are the examples that we can learn that are practical that might not necessarily come from digital governance, but that are also, good models that could be applied? So I'd just like to open up this discussion for good examples that give us hope, because we human rights people sometimes get criticized for being too critical. So let's hear some good examples. Tariq, please.
Yes, thank you, Meg. Well, previously we were talking about challenges, but I think that the situation is not that bad as we think, and we have to face it because we want it or no, we are in a digital decade or a digital century. We have the AI coming and artificial intelligence coming, so we have to adapt. One of the best practices, before to move to the best practices, we should also I want to mention the barriers or the challenges that face the community is the access to the digital, the access to the internet, the access to the tools, smartphone, laptops, and also the lack of the legacy, the digital legacy. Um, for example, I will take the example of Morocco. Morocco is leading UHC, a huge project for UHC trying to connect all the health system and insurance in one. But the problem is, for the lack of uh, capacity to manage this, or the lack of the tools, people do refer to public cyber. So public cyber, either to have an appointment, either to register in a system, and this public cyber are external, independent, so they have the access to all information. So this is one thing that we have also to provide by leading these efforts. And I think it's a complicated equation, because I'm speaking from my community perspective. We want to access, but at the same time, to go further, we need studies and research. And for these studies and research, we should collect informations. And here I open a point. For example, I'm gonna take the stigma index study that GMP Plus is leading across many countries. And when it comes to the stigma index, many countries agree with it, because the information goes to a server, to a server, an outsider server. But some countries says no, this is a sovereignty information, and we want to keep it for us. So this is an equation. So I think to go further, we need database information. We need concrete information when it comes to stigma or access to health. Now back to the innovations. I think one of the important lessons came from the COVID-19 pandemic, and in several countries in the region, community-led organization played a crucial role in maintaining access to services, and when many of health systems were disrupted. For example, in Morocco, Tunisia, and Lebanon, the community organization used their existing communication channels, the digital tools, and community database to ensure that the continuity, and especially for the IRVs, as well as the access to the prevention tools and the STI services and psychological support. Why this that was a success story? Because this organization already had trusted relationships with communities and knew how to reach people quickly. So they were able to identify urgent needs, coordinate treatments delivery, and maintain communication with communities even during the lockdowns. We have another example, which is I was one it was early in 2012, 2013, when we what we call the Key Population Sexual Health Clinics. It was an initiative led by community-led organization, implemented first in Morocco and initiated by community-led organizations. Now it's implemented also in other countries, but always led by community-led organization. So these clinics combine face-to-face services with digital tools to improve access to prevention, testing, and sexual health services. And the digital platforms are used for appointment coordination, but also to follow up communications and connecting people to appropriate care. So the success story here was, at that moment we were struggling. We have people at high risk that having like syphilis or other STI, but repeatedly they have this disease. And thanks to these tools or this digital historic, we knew where there is the lake, where there is the problem. So to be optimist and say that there is an interaction between community-led organization and governments. Now in Morocco, the Ministry of Health wants to engage in this clinical health system dedicated for community, especially LGBTQ+. But the question will come again, will be this trust. So here we really need to work to build this trust. And if we want to build the trust, we need to work on laws that criminalize communities, because you can't ask someone to go to a institution where he knows that he will be instead to be a victim, he become culpable. So just I'm gonna give another example of digital risk that we had during the COVID. It was in Morocco as well, where we have an influencer from the community. During COVID, everybody were very excited with with Instagram Live and all this, and he was insulted by some people, and to defend himself, he just gave the names of date application for the community, and 24 hours started harassment, suicide. People was chased from their home, and it was a very disturbing situation. So today we are talking about AI. Many people give alarms about AI risks. But if there is in the digital, there are risks. So it's up to us as human, as activists, to manage the risk and take the benefits from this, from the digital and from the information era that we are facing. I think
Yeah.
it's I'm really happy to have you as university and Dr. Hassin from human rights and professors, because it's it's an intersectional issue. It's not only health ministries or universities. No, it's a complete issue. Especially we have to work quickly, because now the community-led organization that was leading a part of this role are facing funding
The
crisis.
funding cuts. Yeah.
Yes, we
Yeah.
have to manage this. I will stop here, and we are here for other questions. Thank
Thank you,
you.
Tariq. I mean, just really, really interesting to reflect on the trust issues, right? Because you were talking about these challenges of trust with platforms versus the challenge of, the reality of trust among communities where that trust has been built over time. And so when we talk about digital trust, how can we start to build more on the existing trust that is developed among communities? I think that's an interesting challenge for us, and maybe a question for some of our funder colleagues to be thinking about. Patty, I see your hand is up. Please go ahead.
Yeah, I also just wanted to share that we've come quite a long way over time in many ways. The fact that we're even having this conversation, I think, is incredible progress. When I started my PhD research in 2000, 2001, I was looking at health-related uses of mobile phones in Egypt, which is where I'm from originally. And at that time, you couldn't find women that had mobile phones, right? And so I think I had I was doing an ethnographic study, and I had 70 in-depth interviews, and I think I had 5 women total that I could find that had a mobile phone. And now you fast forward to where we are in 2026, and we see strong correlations between women's mobile phone ownership and primary healthcare outcomes. And that is part of the work that we've been doing on the digital health exemplar study at Hopkins. Across the board, one of the best indications of increases in primary healthcare through digital transformation is women's mobile phone ownership. And Ghana has taken a very proactive approach to this, and they're seeing some interesting results between their access issues and health outcomes. And so I think now we're kind of at a place where we're very advanced, and we now need to kind of take a step and look at the full equation to become a lot more systematic and intentional in the way that that we are doing things. As part of Health Enabled's work with Gavi, the Vaccine Alliance, they included gender intentional approaches to digital health in their vision. And as part of the monitoring, evaluation, and learning of that strategy, what we found was that when interventions took a gender intentional approach, they were able to improve immunization outcomes more significantly than when they did not. And so we're learning a lot as we're kind of going along and progressing. We're also seeing that, we did a gender study in Ethiopia, And there was a huge gap between intention and operationalization. So they have a gender digital health strategy, even as like a sub strategy of a national digital health strategy. They have gender units within the Ministry of Health, etc. But it's not sort of changing things necessarily on the ground. And in order to do that, it really does require a lot more engagement at the community level, as Tariq was just talking about, and ethnographic work to really understand some of the cultural dynamics and some of the power dynamics and struggles between different populations and hierarchies within the health system.
Thank you very much. Really interesting examples there, and really nice to also have that data showing that that has an actual effect on health outcomes. So thanks so much for that. Eamon, back to you.
Yes, so I mean, I just wanted, for the sake of the discussion, really, to tell you a specific story about. So Egypt geographically is split into 26 or 27, quite debatable, regions, or governorates, as they call them. And one of them, which is called Wadi al-Jadid, so this is in the extreme southwest of Egypt. So it's the corner of Egypt that is most like the closest to the borders and the least served by services. Okay, so this governorate, one of 27, the surface area of this governorate is larger than Germany, right? Yet, when it comes to services, it is extremely underserved by healthcare services in general. And while the new digital health initiatives and attempts to implement telemedicine services have been going on, they have had no gynecologist or obstetrician for a couple of years visit them. So services were provided by general practitioners, and they were very limited in this sense. And the argument for the organization trying to provide telemedicine services there was that telemedicine would save lives in this context. It would literally make the difference between no services and healthcare services provided, especially to women and people who will not be able to access a specialist or a consultant. And what happened, practically speaking, is that one of the main reasons why they took so long and it wasn't possible to use digital health services to provide these services there was out of fear regarding data privacy, data confidentiality, where are the data going to be saved. And this context, our argument was that we cannot deny access to services because we're afraid of what would happen with patients' data, because in the end, accessing services in itself is a right that needs to be maintained. And we cannot take patient confidentiality as a pretext not to provide these services. So yes, we need to take the needed measures to ensure that the patients' data are kept. But if we're talking about families of people who are underserved when it comes to healthcare services and who have not seen a specialist for years or maybe even never, do you think that the data of this patient who is requiring a certain medical intervention would be more valuable than the life of this person who is not going to be maintained because we refuse to provide these services? So I'm just challenging the conversation a little bit, because sometimes we tend to put requirements for inclusive and respectful rights when it comes to patients' rights, strategies when it comes to patients' rights. We put this as a way to obstruct the provision of some services, and I think it defies the purpose a little bit. So I just wanted to hear your thoughts about that.
Interesting provocation, Eamon. And, I just also reminded me that I wanted to respond to Arash's earlier note about global north, high-income countries having more robust data protection and privacy protection. I'm in the UK, where we just signed this massive deal with Palantir for our health data. and it's a really controversial issue here. So I think, you know, we have to challenge ourselves to be able to do both, right? I mean, it must be solutions to that. But I see Khaled has had his hand up, so maybe he's got the solution for us. Go ahead, Khaled.
Oh, thanks. Solutions, solution pathways, and promising practices to be very, positive. No, just to link to Eamon's points, we have been seeing also some of these promising practices that come out of community-centered activity, and it's often civil society driven when you have, for instance, hybrid care delivery. So offline first systems in order to be practically inclusive, and have community health workers models that are expanding through equitable access while strengthening like the collective agency and trust. And the second point, which is really important that we see, is this inclusive design and safeguards to have co-creation. And at local level, we see instances and practices where women or older persons with disabilities are partaking in co-creation in order to ensure accessibility and also cultural responsiveness, adaptability and uptake, but also data governance at the local level and safeguarding approaches. They come often with the community and civil society contributions. Just wanted to share this. Thank you.
Great, thank you. Just replying in the chat here, I see we're going to have another little debate going on around the question of privacy and balancing interdependent human rights, which is always a continuing challenge. Eamon, I see your hand is still up. Is that a legacy hand, or did you want to come back in?
Yeah, that was a legacy hand.
Okay, all right, thanks very much. Catherine, and then we're going to open things up for discussion. So hope you have good questions ready, and we'll let you either post them in the chat or to raise your hand if you want to and speak. But Catherine, over to you.
Yes, I was just going to quickly echo what Khalid and Tariq both said about, some of the learnings from, the civil society groups, and also during COVID-19. In India, what happened with the COVID experience and, rolling out such a large digital platform and then having a register for the vaccine during that time, we saw how that could also fuel inequalities, especially with older populations and some of the more marginalized populations. But we did also see a response there, and drawing from the HIV response, where you had the community-led organizations really start to roll out different outreach centers to help them register, and then the government learning from this too about when you have these inequalities and that the need for digital literacy. So when you're trying to have all this digital health interventions, you do have a lot of populations that are just not going to be able to navigate these digital health systems at this time, and the need to work with the community and have them inform the responses. And so I think we had a lot of good learnings from that situation in particular. I'll stop there. Thank you.
Thanks very much, Catherine. Arash, we'll give you temporarily the last word, then I'm going to hand over to Tara to moderate the Q&A. Please go ahead.
Okay, just following what Catherine said, I wanted to bring another angle of what we saw during the COVID pandemic. So there were a lot of digital solutions that were generated, sometimes nationally, but sometimes actually by the providers themselves. So a clinic, a hospital will do that. And it actually augmented informal use of these technologies, using mobiles for the collection of data, etc. And that's another thing that should be always borne in mind. I mean, all these issues of access, equity, and safety, ethical considerations are also augmented because we do not, if there is no strong system that responds to the need. People go for solutions for access, but those solutions may generate new challenges.
Very true. That is definitely a challenge that we saw in COVID. So would love to continue, but it's my job now to hand over to Tara, who will now continue to facilitate this discussion and also open things up for questions. Tara, over to you.
All right, thank you, Meg. Thank you, everyone, for your contributions. I'm just going to give the audience a chance to raise any questions. before I ask my own, or even allow the panel to ask each other questions or continue the discussion. So let me just see if there's anyone in the audience that would like to ask a question. Please raise your hand or please enter your question in the chat. Okay, I'm not seeing anyone raising their hands. So maybe I'll just ask one of the few questions I have. And this would be directed to Ayman and Tariq, because I think, and Catherine just mentioned literacy, and I think that's an important discussion on its own. And it's great to hear the communities are getting engaged and collaborating with government to different degrees on these issues. So my question would be, what would you say is the state of digital literacy readiness in communities across this, different populations, and what needs to be done to ensure that inclusive involvement and their inclusive involvement in digital health strategy and policy processes?
Sure. That's yeah. Let me. Okay, so when it comes to digital literacy in particular, we've had an interesting experience, and I love the comments by Patty regarding the number of people that and women who had access to mobile phones and how it is now. We see now that many women in particular are carrying out and managing entire local businesses from their phones and from their social media pages. And those women didn't have access to anything. And some of them have even problems reading. Some of them haven't been to schools even in some cases. And, their families and their children, they help them in this. And this is something now that is going on at an extremely accelerated rate. However, I would always say that when it comes to digital health in particular, digital health doesn't have to be confined to a person holding their phones. Because in many cases, and we've seen this in some of our work on a community level, we have a project called Nasah, which works on ensuring people who need healthcare services get to access information about these services and get to receive these services from the public routes. So instead of having to, go in loans, pay out of pocket, we tell them, by the way, do you know that you have the right to this health insurance package because your child is in schools, for example? We help them with the procedures and we ensure that they get to access these services in the end. And of course, the demographic that we're targeting here are primarily people who have limited literacy, and especially when it comes to digital literacy. So what we do is that we partner with local NGOs that provide services to these families and these women, and we work on the digital literacy of the NGO members who are going to be the point of contact with the community members. So it doesn't have to be direct. We don't have to wait and to work on the digital literacy of every single person in order to use technology to give them access to healthcare services. We can always resort to intermediaries. We can always resort to locally available resources and organizations that can bridge this gap. And I think this is the easiest way to go, because when we enforce it, and we have had an experience like this in Egypt where the government said, you know what, when it comes to any government payments, we're going to make them digitally. So no more cash. And of course, this is quite catastrophic, because what happens in the end is that some people don't access services at all because of this hard barrier.
Absolutely. Yeah. Thank you so much for sharing. I'm not sure if Tariq has anything to add.
Yes, just to add about when it comes to legacy and digital knowledge, when it comes to community, we recognize that there are difficulties to access to health and to digital access for the whole population. I mean, challenges. But when it comes to community, it's a double challenge, because it's not only to access to the health, but also to protect itself. And in this point, either in most countries in the region where some community project was implemented by private donors and partners, we were always focusing on cybersecurity, and this was very important, and it's really always a topic that interests the community a lot. And I gave before the example of the public cyber that help people, citizens, to complete their forms, and there is a risk for the big public we can, but what about you can imagine when it comes to community, if for example, if uh, to, to get a better consultation with the doctor, there is one thing important. We should say the truth. And I think at this day, a trans or a gay or a lesbian can't say the truth to a public doctor because, as said before, instead to become a patient who is looking just for access to treatments or medicines, he become a culpable. So this is why we are really focusing on cybersecurity and the I repeat again, the digital health system must include strong safeguards for privacy, confidentiality, and ethical use of sensitive health data. I really insist on that because if we do, we can work a lot, but we're gonna lose efforts and money. So we really should work on safeguarding. I respect Ayman, you thought that we can't protect everyone, but when it comes to safety, I think my role on our community-led organization, we should advocate for that. So I think this is very important. And yeah, so it's still complicated, but we did our best for community by providing these cybersecurities, new technologies. But as I said, we can't cover everyone. We don't have the fund to do that. And even communities who are in the rural areas, in mountains in Morocco, or in villages in South Egypt or in Yemen or whatever, not everybody has the access to that. So yeah.
Absolutely. Thank you both. I think you've both reinforced the importance of having civil society and community groups and organizations sort of speaking for the community. So not looking at it at an individual level, but using the systems and the processes and organizations already in place, working around these issues. So I think that's very important. I think my next question, I think there's no other questions in the chat unless the audience wants to chime in and ask a question. But my next question was for Khaled. You talked about the government and accountability gaps and how the frameworks was seeing are regulating tools and not ecosystems, which I thought was very interesting. So I was wondering, in your experience, what kinds of accountability frameworks for human rights inclusion do you think need to be embedded when it comes to strategy or policy implementation and evaluation in digital health?
Thanks, Tara. Like there are three priorities. The first priority really is to anchor the normative framework in human rights and that regulation is human rights compliant. And with the human rights mechanisms, the independent mechanisms, member states have signed up to the minimum obligations. And when I hear Tariq on privacy and data confidentiality, it's about safety, and it's a bare minimum to ensure that data is protected. And here, the normative framework having digital health strategies aligned with the Article 12 of the ISESC, which is the right to health, and we have the framework obligations under conditions of digitality, meaning that availability, accessibility, and acceptability, as well as quality, needs to be met. Often things need to be clarified and highlighted in order to make also clear to states and local authorities and policymakers how to strengthen the regulatory frameworks covering AI, data governance, and private actors also, a very important point, who often drive emerging technologies. Second point is really self-determination and participation and safeguards. Protecting individual and collective self-determination goes through empowering information and civil society plays a key role. I keep repeating it, but since coming from the Office of the High Commissioner for Human Rights, our stakeholder group comprises civil society actors on all topics, and hence the conceptual approach, privacy, but also informational self-determination, really ensuring that consent is or ensuring strong consent regimes and independent oversight is one of the key mechanisms. Another point is how to institutionalize meaningful participation for all groups, women, girls, but also older persons and representative organizations. Again, civil societies is key here to ensure that that participation or that the civic space there is provided and used, and accountability through systems approach. And I think the conceptual approach of digitality is also something that not only enables us to assess and examine the human rights obligations in order to generate actionable recommendations for all, to show where the gap is with the bare minimum, and hence institutionalize human rights indicators and disaggregated data systems are key elements to ensure that human rights monitoring informs budgeting, procurement, and reform when you try to have member states complying with the minimum obligations. I think it's key to see that it's not only technical but relational, that they're making it clear what are the or demystifying also what the obligations entail, always highlighting it's about the bare minimum. When we talk about privacy, information, and self-determination, it implies safety of people and data sovereignty. And there, to reflect the lived realities, human rights language may help. And I stop here.
Thank you so much for sharing all those very important insights, particularly institutionalizing human rights indicators, as well as gender indicators, I think is a very important discussion. I'll probably ask Catherine a question and then Patty as well to begin reflections on sort of what we want to see looking ahead. So Catherine, you had mentioned how there's more institutional coordination and governance. So I was wondering, what are you seeing are some of the best practices with respect to cross-sectoral participation in the space, or what needs to be done? I know there are a lot of platforms coming up at the global level and regional levels, but how can we improve those systems, make them more accessible, or what else is needed to bring different stakeholders and sectors together?
There we go. Thank you, Tara. I think, again, it goes back to what some of the other colleagues have already said. We need to look at what we've done in the past, not just in the digital space, but when we're drawing from, whether it's the HIV response, TB response, from most of these other, and then even outside of just the health response, looking just at human rights, the gender response, how we've started to look at this. And when we've had the community groups there and looking that, these need to be embedded from the very beginning of a strategy design, not as an afterthought. And so it does really need to be systematic in the approach and institutionalized. As Khalid was just saying, that with the human rights indicators, embedded in this, that, we can't just have it as an ad hoc. So when we're looking at this, for strategies to adopt a whole government approach that, as I said before, it sits at the intersection of this. But we need to not only involve the ministries of health, the ICT, but I mean, we have different examples from, if we look at how the Global Fund has had the CCMs and we've had, the PCB with UNAIDS, different kind of mechanisms that we can draw from of how we have different ideas of coordination from a global level, a regional level, down to the country level to really help with the accountability and transparency of these strategies and to inform them. And then when we were talking about institutionalizing participation, as Meg and everyone else has highlighted, it's been really limited consultation beyond technical ministries. And so we really have to engage with the civil society communities and affected populations, and both during the strategy development, but also in the implementation. As we've seen, once we start rolling out, that there may be impacts that we didn't either see, and as others have talked about, that it may drive further inequities that weren't envisioned, and we can't really notice how or anticipate how those are seen. And also as we have the emerging health technologies coming out. And so to ensure that the policies respond to the real needs and build trust in the systems, we need to have them both in the design, but also in the implementation. And I think we do have experiences that we can draw on from other, whether it's in the health sector or in other experiences from, the gender work that we can all draw from too. So I'll stop there.
Amazing. Thank you so much for summarizing the discussion, I think, really well. We have a comment in the chat. I will read it out before giving Patty a chance to share some reflections. This is from Paul Hunt. Your work is inspirational and indispensable. It's incredible. My question is, do the people, the masses, grasp and call for human rights? I think obviously Khaled will be best suited to sort of get us started and answer that question to the best of his ability for now. Yeah, please go ahead, Khaled.
Thank you. And fun fact is that in many of my advocacy work and also with academia, I use an interview that Paul Hunt gave in, I think, 2009 that addresses this question to explain what human rights work offers or the right to health work looks like and what it is in concrete terms. And I still use it, and it is a challenge. I think often, like what we have seen in the past is that the kind of association with a political movement kind of made it for many people difficult to actually get back to the essence of what human rights are. I think when we demystify, when we keep it very concrete and technical, surprisingly, when we use human rights budget analysis and we ask stakeholders, it's a technical tool that people can relate to. I don't know what barrier exists, but there are barriers of some where the understanding perhaps is not always there. But I think much more needs to be done. A lot has been done. I think we have new constituencies on new topics. They use human rights language, and I think that's very promising. I'd stop here.
Thank you so much. I hope that answers your question, Paul. But I'm sure that's a discussion that we can have over and over again, truly. But yes, a lot is being done, particularly from civil society groups, I think. I'm gonna hand over to Patty to sort of just reflect on what's been said, and also looking ahead, what you see as some of the ongoing or upcoming opportunities that should be leveraged as we take forward these discussions. So over to you.
Sure, thanks, Tara. And this is like social change, right? This is something that we're moving through, a process. And so we all want to be in like gender transformation. We want to blink our eyes and wake up tomorrow and be like, okay, everything is good. We're all in a good place. But it takes time and it takes a lot of very like intentional effort. And I'd say like three concrete things. One is we definitely need better representation. We need thoughtfulness in who is sitting around the table when governance structures are being put into place, when policies and strategies are being developed. In the Ethiopia analysis, we had, 25 people involved in the digital health strategy. 2 were women. In the immunization strategy, 22 people were involved, 0 women. This is a problem. And it doesn't take much to just try to make sure that the people that are being impacted by the programs are sitting around the table and coming up with the strategies and the solutions to address them. If half your population is female, half of the people involved in your policies or strategies should be female. It's that simple and straightforward. The second thing that we're seeing is that there are new methods to embed values and considerations into technology itself. And so safety, privacy, if you can imagine it, it can be designed into tech. I grew up with 2 computer scientist parents. If you can imagine it, you can build it. So we should be thinking about how do we embed these values into technology. Gender Mag is one approach that has been developed where you can literally bug fix for differences in cognitive processing between men and women into technology programming itself. And Excel has been redesigned with this in mind. Certainly a lot of the digital health interventions that we're using and implementing can be like redesigned with this in mind. And then the measurement piece, that which is measured gets done. It's really exciting that this conversation started with measurement, the work that you guys have been doing. We need to continue to measure and hold ourselves accountable to the change that we're looking to see through these programs. And the outcomes will follow. Like we have seen it, that you can really improve health outcomes and equity for people when you take these things into account in a very systematic and proactive way.
Amazing. Thank you so much for that positive spin on this discussion and basically reminding us that it is possible if we do things the right way. So thank you so much, and thank you again for co-sponsoring this event. As my colleague puts up the PowerPoint, just want to add that we usually get a lot of people watching the recording, so we will share it on our website, and we can share it around as well for you to send around. We normally get a lot of people rewatching the discussion. So if we do get any questions, I will forward them over to you. So Javier, please bring up the slide for just a quick wrap up.
Should we, Ayman and Tariq have their hands up just in case they want to say something last minute before we close up?
We only have 2 minutes left, so I think Ayman, if you can keep it brief, that would be appreciated. Thank you.
Sure. So now I was just stunned that Mr. Paul Hunt is here. We've met in 14 years ago or something in Salzburg. And one of his very key writings that has been inspiring since then is about the impact of using the right to health language when it comes to advancing right to health of the population. And this has been inspiring ever since. And so in this context, I think adopting a rights-based language when it comes to digital health as well is most likely to prevail, because I just want to tell you, sir, that It has been inspiring, and since then we have managed to include the right to health in the Egyptian constitution based on your intervention and based on your inspiration. And it does make a difference. And now in Egypt, we have a universal healthcare coverage scheme that is being implemented. So I can provide you with numerous evidence that absolutely substantiated this. And when it comes to digital health, I think it's time to use the same approach because it works.
Amazing. Thank you. And thank you so much, Paul Hunt, for joining us. It's a pleasure to have you join the discussion. I'm so sorry, Tariq, we may have to wrap up, but please feel free to use the chat to share sort of your thoughts. Javier, please, could you put up the slide so I could just share? Yes. So the Digital Health and Rights Project will be hosting a side event at the 79th World Health Assembly on human rights in digital health and AI strategies. We're hoping to have speakers from the WHO, Global Fund, the Human Rights Office, and others. So please feel free to register your interest. We are still in the planning process, but my colleague will share the link in the chat, and I'll also share it around for you to share with your colleagues as well. Thank you all so much. I'll pass over to Meg just to share final words. Thank you.
Yeah, thank you. And so sorry, Tariq, we didn't get to hear your comments, but I see a really beautiful, eloquent statements. Maybe we can share that out on LinkedIn afterwards. Thank you very much to our panelists. Thank you to Patty and Health Enabled for co-sponsoring, and our colleagues at WHO, UNGP, Ayman, Tariq, Khalid. It's been really just a pleasure. And thank you so much, Tara, for your gracious co-hosting. We hope to see you on the 20th. Have a great rest of your day and take care and stay safe. Bye-bye.
Thank you so much. Thank you. Have a nice day.
Thank you.
Thank you, everyone.
Bye.
Bye-bye.